Welcome from Geneva to our third and last session of the series of these webinars, which we started last week, Friday. Today's webinar is going to be on enhancing uptake among adult men and transitioning to adolescent-focused sustainable VMMC services. I'm going to introduce the two main objectives of this session, which are briefly. The first is to share evidence-based interventions to enhance uptake of VMMC among men with a focus on service delivery interventions and economic compensation, and also to share the WHO framework on sustaining VMMC services and discuss country perspectives to transitioning towards sustainable VMMC services. A warm welcome, colleagues. My name is Lisa Zembe. I work at UNAIDS at HQ in Geneva. I'll hand over to Rachel for the welcoming remarks. Thank you.
Good afternoon, good morning, good evening to everybody. You are the real heroes in this VMMC, coming to the third session we have, and I can see that there are already a lot of people online. We're going to start with a poll, and that really follows on from yesterday's session. There was a lot of interest and a lot of questions on adolescents. So we're going to ask you what you think about continuing this discussion. Can we have the poll up? So we want you to answer. Would you like us to do another session to discuss VMMC in the younger adolescents, that's the 10 to 14-year-olds? Would you like us to do that specifically? Ooh. I can see a lot of votings going on. It's very exciting when you're watching all this participation. How long do we give people?
Give another 10 seconds.
Yeah.
10 seconds. And yes, if you've got other suggestions for other things you'd like us to follow up on, please write in the chat box. We'll collect all those, and we will definitely decide. Okay, so I think it's very clear. There is a lot of interest in this, and I thought, maybe we're a bit foolish to even do this poll, but it just does reinforce that what happened yesterday, where people were discussing these issues, and lots of opinions in pro and against, and it's a very complicated issue. So I think we have a clear signal from you that this is an absolutely hot topic, and we will definitely arrange another similar type of session, but more interactive with more country experience, more of your voices on this topic. And Julie and Wale and Lysias will find a time for us to do this without losing the momentum. So we will definitely do that. Julie, do you want me to share the housekeeping slide? Should we just have a look at that? If we can put the house in. So you can, if we can have, is it the next slide? Oh yeah, here we are. So just really to say that this this webinar is also available in Portuguese for Lusophone countries, so please click on to that if you would like to listen to it in Portuguese. If there are any questions that you have, anything you want to suggest, please put it in the chat. Katie and I will be trying to follow the chat and try and summarize some of those things and bring those to the speakers. If there's any problems with the IT, please let the ECHO team, so write ECHO IT in the chat, and they will respond to that. Put your name and organisation, and everything that we present today and it's been presented in the previous two sessions will be shared. We'll send you that link by email. The sessions are all being recorded, so you can share them with colleagues who haven't been able to attend, or re-listen to them if you want to. And there will be a feedback session and a certificate of attendance. Again, look in the chat for the links for that. Okay, so we'll get started. And just to say, this as Lysias has said, this is really our final session, focusing on two main areas. One is enhancing uptake, and when Julie was thinking many months ago about updating the VMMC guidance from WHO, one of the big questions that came out and was prompted from ministries of health and implementers was, how can we reach men better? How can we encourage men to take up this service? We've done fantastically well, and I think all of you who are involved with VMMC programs, you really should be proud, because you have done fantastically well, and we now have 25 million young men who have reduced HIV acquisition risk through safe and effective VMMC services. So how do we reach the rest? And the second part of the session really builds on that in how do we move? We've done the kind of emergency bit. We've run what we call the catch-up phase, and how do we now transition to make these services into the long term and make them broader and sustainable? So that's what we're focusing on today. So I will hand over to my fearless colleague, Julie Samuelson, who will set the scene for us.
Thanks, Rachel and Lysias. So we know that to reach the 2030 HIV prevention targets in East and Southern Africa, there's a need to increase VMMC uptake among adult men, including those who are at higher risk of heterosexually acquired HIV. And early program efforts did focus a lot on generating demand, but more strategic approaches are needed that address demand and supply barriers, and that align also now with achieving universal health coverage. That is, that people have enough access to the needed health services. So in this guideline, we share a framework for achieving service coverage on health interventions, focusing on VMMC. We also share with you in this chapter the evidence base on interventions that have peer-reviewed evidence. And this is in particular on service delivery and economic compensation, as well as 11 case studies that had some evidence, predominantly programmatically driven evidence. So the language and the frame of reference that we're using in this chapter on enhancing uptake among men, and again in support of universal health coverage, builds on what is called WHO's Innovate, leaving no one behind, in order to achieve effective service coverage. And effective service coverage is described as people who need health services obtain them in a timely manner and at a level of quality necessary to obtain the desired effect and potential health gains of that intervention. So all health services, goods, and facilities must be available, accessible, and of good quality, and acceptable to those intended to receive them. And you can see those by each of the bars in this graphic. The process recognizes that some of the target groups, in this case adolescent boys and men, may face particular barriers and facilitators, both on the demand side, such as awareness and knowledge, but also on the supply side. The barriers across these domains that you see on this slide result in limited uptake, which slows progress towards effective coverage and the public health goals for HIV infections averted. you will find in this chapter some tables where the interventions that have been looked at, as well as barriers that were identified through a literature review, are organized by these domains on this pathway to effective service coverage. The interventions included are both those from the comparative studies as well as the cases. And this is just an example of the table that's shown here. You can look in the guideline to see this in more detail. So to determine the focus of this chapter, the first thing that was done was WHO commissioned a scoping review of the peer-reviewed literature on enhancing uptake. And that identified, the idea was to determine what kind of evidence was out there. And it was decided that there should be at least 3 or more comparative studies on a particular types of interventions in order to do a systematic review. So systematic reviews were undertaken only in 2 areas, and that was on the service delivery and economic compensation intervention areas. And you can see the PICO questions that were asked, and these PICO questions informed the evidence reviews that were undertaken, and which you will hear more about in just a moment. So the main points, and you again will get more details on this, from this review of evidence and the discussions in the guideline development group, were that actually there was no recommendation made on service delivery or economic compensation, given the limited evidence that was available, the varied types of interventions in diverse types of settings, and what seems to be context-specific considerations. However, both service delivery interventions and economic compensation did show some increases in uptake. They did address access barriers, and the service delivery interventions also addressed awareness and self-efficacy and acceptability. So for the service delivery innovations, in general, there's a need to consider approaches to best suit a population using closer to the client and more person-centered delivery changes. This is nothing new, but we bring emphasis to this. And regarding fixed compensation, in particular, the fixed amount of compensation did show effect, but there's a need for multiple considerations before any settings would want to use this. And it requires community engagement. It requires considering the specific context as well as the broader health system's perspective. And so with that, I'm going to stop, and you will be hearing more about the details of these over the next 40 minutes or so. Thank you.
Thank you, Julie, for that summary of evidence. Our next speaker is going to be Caitlin Kennedy. She's the program director of the social and behavioral interventions at Johns Hopkins University. Caitlin will give us a summary of a review of peer-reviewed evidence on service delivery interventions and economic compensation. Over to you, Caitlin.
Great, thank you. So I'm here to expand upon what Julie just started to tell you a little bit about these 2 systematic reviews we conducted of peer-reviewed studies looking at service delivery changes and economic compensation. So the first is service delivery changes, and how we defined that was changes to the ways in which VMMC services are provided. And that could include a wide range of things, including improved training of providers, changes to the physical space or layout or location, changes to the structure of health services, providing additional information, education or communication, or co-location of VMMC with other health services. Next slide, please. So when we did our systematic search of the peer-reviewed literature, we identified 9 studies that met our inclusion criteria. These were 4 randomized controlled trials and 5 observational studies. They came from 5 priority countries in Eastern and Southern Africa, South Africa, Tanzania, Uganda, Zambia, and Zimbabwe. They were conducted between 2009 and 2016. And the age range of men included in these studies was mostly over 20 years, except in the school-based studies, which I'll be talking about momentarily. And all of these studies measured VMMC uptake as one of their outcomes. We found a wide range of interventions, as expected, and in order to try to bring some semblance of organization to these topics, we grouped them into 3 broad categories: community-based interventions, including home-based interventions, school-based interventions, and facility-based interventions. Next slide. So these were the 4 randomized trials that we identified. This is a brief description of the studies and the interventions included. You'll see at the top community-based, then facility-based, then school-based. And the interventions, again, were quite diverse, ranging from text message reminders to intensified demand creation packages, to service facility changes, to group-based education, peer mentoring, engagement of female partners, trained coaches, etc. Really a wide variety of different intervention types. Next slide. And then these were the 5 observational studies we identified, again, from a range of countries, both community-based and school-based, and again, a wide range of different intervention types, from different service delivery, task shifting, promotional activities, to outreach campaigns, to using GIS to strategically plan for services, to using a phased approach to community sensitization and engagement in schools, to soccer-based promotion using mentors and coaches. Next slide. So here's a summary of the results in terms of the impact that these studies had on uptake of VMMC. You can see the same categories listed here, organized by type of intervention: community-based, facility-based, and school-based, and separating out the randomized controlled trial evidence from the observational evidence. And if you look on the right-hand column, you'll see the relative risk in these studies. And because the relative risks are all over 1, these studies generally found that these interventions did increase uptake of VMMC. However, if you look at the absolute numbers of people in the intervention and comparison groups, they're relatively small total increases in effect. Next slide. So this table starts to summarize the evidence that I just presented and move it towards the decision framework that allowed the guideline development group to come to the decisions that Julie mentioned a few minutes ago. So in terms of the evidence that we reviewed, 2 of the considerations about that evidence are the quality of that evidence and then the benefits and the harms that that evidence suggests. So in terms of quality, we did identify high to moderate quality evidence from 4 randomized trials and low quality evidence from 5 additional observational studies. And although this evidence was of high to moderate quality, if you look in the right-hand column at the judgment, the heterogeneity of these service delivery approaches and the settings made a recommendation around this difficult. Similarly, around benefits and harms, there was a finding that these service delivery interventions are acceptable and did increase uptake in VMMC services in various settings. And again, after consideration of this body of evidence, the guideline development group felt that although the evidence was high to moderate, this heterogeneity made it impossible to make a global recommendation that the benefits of such changes would outweigh any potential harms. So in addition to this peer-reviewed studies on the impact of these interventions on VMMC uptake, the guideline development group also considered several other factors in coming to their judgment. Next slide, please. And these are some of those additional factors. So they considered the acceptability of the intervention, the resource use and cost of the intervention, issues of equity and ethics, and also feasibility. And for these, we actually did additional reviews of the literature and found additional evidence for some of these factors, which are explained here. And I will move to the judgment column on the right in the interests of time. So what we found overall was that most of the service delivery approaches that had been studied were considered acceptable. Participants found them to be useful and perceived to be helpful in increasing VMMC uptake. There was mixed evidence regarding costs and resource use, While there were a number of cost studies, clearly the diversity of studies really makes a judgment about cost and resource use difficult to say globally. And regarding equity and ethics, there was a feeling that this might make it easier for some boys and men to access VMMC services, but that had to be weighed against other interventions that also have broad health outcomes and benefits. And so the judgment was uncertainty as to what this would do to issues of equity and ethics. And finally, with feasibility, we did see evidence of feasibility across a range of research and pilot project settings, but it was uncertain to what extent this would expand to other settings if recommended globally. So again, for the combination of all these reasons listed here and the evidence on effectiveness, as Julie mentioned, the guideline development group decided to make no strong recommendation to all countries to do these activities, but that they are potentially useful in many situations. Next slide, please. So now I'll move on to the second systematic review, which was on economic compensation. And we defined economic compensation interventions, financial incentives, or demand-side financial incentives for potential VMMC clients. So importantly, this was providing some sort of financial incentive to clients rather than providers or anyone else. And these types of interventions could include providing money or gifts in exchange for completing at least some components of VMMC, generally counseling, or undergoing the VMMC procedure. It could include reimbursement for costs associated with lost wages or travel expenses to get to the clinic for the VMMC procedure. And it also could include providing the opportunity to earn rewards in the form of lotteries or other systems where not every individual is guaranteed to receive compensation, but there's a chance of receiving compensation. So this is how we defined economic compensation. Next slide, please. And when we did a review of the peer-reviewed literature, we identified 8 studies that met our inclusion criteria. 6 of these were randomized controlled trials that offered moderate to low quality evidence, and 2 were observational studies that offered very low quality evidence. And when I say moderate to low quality and very low quality, that's based on the grade system for reporting quality. Countries were diverse, again, including studies from Kenya, Malawi, South Africa, Tanzania, Uganda, Zambia, and Zimbabwe. The age range of participants was mostly over 18 years, except for one study that targeted adolescent male secondary school students. And again, all of the studies included in this category measured increased VMMC uptake as one of their outcomes. And again, because of the breadth of the definition that we used, we found a wide range of interventions, including lotteries, food and transport vouchers, lowering the end user's price of VMMC services, conditional cash transfers, cash payment for VMMC referral, and non-monetary gifts, such as tickets to a soccer game. Next slide. So this is a meta-analysis forest plot showing the summary data when we combined all of the randomized controlled trials together, looking at their impact on uptake of VMMC. And I note that this is a smaller number of studies because some of the studies we felt were not combinable in meta-analysis. But when we looked across the 4 studies that were combinable, we did find an increased uptake of VMMC associated with these interventions. So if you look at the risk ratio column down at the bottom is the overall summary effect of 5.233. However, again, if you look at the absolute numbers in the intervention and control groups, these are relatively small increases in many cases in terms of absolute numbers of new clients. So it varied across study, but less strong. Next slide. So again, moving this to our evidence to decision table in terms of quality of the evidence and benefits and harms, we did find a moderate to low quality randomized controlled trial evidence that indicated economic compensation interventions are generally associated with improved uptake of VMMC, but very low quality evidence from 2 additional observational studies showed no effect. And with benefits and harms, the guideline development group thought that in the context of broader health needs, priorities, and universal health coverage, that providing economic compensation for a single HIV prevention intervention could have serious negative consequences, And so overall, the judgment here on the evidence was that although the evidence was moderate to low quality, the heterogeneity of service of these approaches and settings made a recommendation difficult. And also that the uncertainty still remained about whether the benefits really outweighed the harms. So in addition to quality of evidence and benefits and harms, we also considered the other factors on the next slide, please. These include, again, acceptability, resource use and cost, equity and ethics, and feasibility. And overall, moving to this judgment column, for acceptability, while these interventions were largely acceptable to those receiving compensation or incentives, there were occasionally expressed concerns from communities and providers about these interventions. Some felt they were not sufficiently motivating or were unnecessary, and one suggested that they might raise community suspicions. In terms of resource use and cost, we found limited information about the resource used and cost. So we found this judgment to be uncertain, and the cost data was mixed. For equity and ethics, the guideline development group felt that compensation could increase equity among men, for example, in rural areas for whom transport costs were a barrier, or by making men more able to access VMMC due to lost wages, or due to that not being a challenge. However, there was also equity concerns around singling out economic compensation for VMMC as opposed to a range of other health issues. And so overall, the guideline development group was did not feel for certain that this would increase equity, and the ethical considerations did not necessarily favor this intervention. And so finally, with feasibility, although these economic compensation interventions have been successfully implemented in multiple research settings, it was uncertain whether this would be practical in practice. And so again, for all these reasons, no specific recommendation was made around economic compensation interventions. And I'll end there, but happy to take questions about any of this evidence base. Thank you.
From those different studies. Colleagues, I think we agree that attaining desired impact of different interventions among men requires these two cascading factors. First, it is attaining the desired coverage. And we have heard from Julie when she gave the summary of included interventions on case studies as well as a framework for achieving effective service coverage. And then to attain the desired coverage, it requires us to understand how to influence the behavior that affects service uptake among men. And we have heard from Kathleen giving this review of evidence on service delivery interventions as well as economic compensation. Many thanks to our two speakers for keeping time. Just a reminder that we've got a chat box. Please feel free to type your questions there in the chat box. At the end of the first part of this session, we'll go through a question and answer session and we'll be able to address those questions. We are trying to move fast as well in today's session because we are trying to buy some time to be able to revisit some of the issues or questions raised yesterday that we couldn't cover. So hopefully, looking at how our speakers are keeping time, we might be able to save some time and revisit yesterday's questions at the end of this session. Next is our speaker, Wole, who is a technical officer here at WHO HQ in the HIV testing, key populations, and prevention, as well as in adolescent HIV programs. Wole is going to speak about a policy for men's health, case studies on enhancing uptake. Over to you, Wole.
Thank you very much, Lysias. And I think this VMMC discussion is an important entry point to talk about not just VMMC, but also men's health in general. Just recently, the Global AIDS Report showed that across the 390s, testing, treatment, and virus suppression, men are behind. And a lot of this usually starts with policy. So when men or whatever the the projects or areas are, when they're missing in policies and strategic plans, then you sort of expect that they're missing as well in practice. And I just point here to this review by Sonke Gender Justice in 2017. And you can see on the screen, so the dark orange and the light orange are program areas where in the different countries, the strategic plans have either omitted men or there is so much room for improvement. And you can see it's just, you know, quite you know, orange and light orange as well, all along from, you know, HIV and gender, all through and across countries as well, many of them VMMC priority countries. So this shows us very clearly that it is really important that we use that you know, opportunity of VMMC, which has done quite well in many countries, to use that as an entry point to include men and that, you know, critical gender discussion in countries. So I'll just summarize just a few key points, and that is that the topic on men, you know, it requires really good attention now. You know, like I said, men are missing across the 390s. It's important that we begin to have that sort of discussion now to ensure that as we're going towards the 2030 goals, we include and engage men as we move along. And sometimes it's not just that dichotomy. A lot of the times when we talk about, you know, engaging men or improving men's health, it's usually compared to women. And we have to say, you know, very clearly, the number of new infections, for instance, amongst adolescent girls and young women is really high. So that focus still needs to be on adolescent girls and men. However, there needs to be that sort of synergistic work and to ensure that we do not detract from, you know, the really important goals of reaching men and achieving the Sustainable Development Goals. Therefore, our policies and our programs need to continue to work to shift those structural barriers, the gender norms, the policies that are needed to improve uptake for men and also improve men's health. Now, there are quite a lot of examples, and we heard from Caitlin, you know, through the reviews and the studies. It's important that we begin to look at those sorts of examples, those studies, those reviews. What is happening in countries, and how can we use such best practice examples to improve outcomes across countries? As part of the work on these guidelines, and you see this, you know, we should share the links as well probably today. There is a specific annex where you would see case studies and examples of how men have been reached in different settings and how such can be used in you know, to share and to be used in other settings as well. And in 2019, we opened a call as part of these guidelines to get those case studies. We had 16 in all, and having been reviewed by reviewers, we were able to select 11 of those cases, which you would find in Annex 5.2 in these guidelines. Most of those examples address multiple interventions across multiple barriers as well. So I'm not going to go into you know, the case studies, but what I can say is that I think we can get a lot of more details, more nuanced details of these examples and studies and reviews and the guidelines, but we grouped them in that annex under 4 broad categories. So you will see examples and studies on improving awareness and knowledge, on improving availability and accessibility to care, you know, as well examples on and studies on acceptability, but also on contact. How can we ensure that you know, critical contact is made between those that require the services, and as well finding their own quality. What are the critical examples? What are the reviews and evidence that show how we can improve and monitor quality across settings? So this is my last slide, and it's just to say, you can see you know, the annex on the screen, but also there is an opportunity for us now to share our examples. I know there's a lot happening in countries, and I want to just implore us to take the time. You know, we're happy to work with you as well on this, to see how we can bring forth the fantastic work that I'm sure is happening across countries on engaging men, on reaching men. How can we put this to bear so that we can share with countries, and these can be cascaded for improved men's health. Thank you.
Thank you, Wale. Excellent summary. I think we are managing to save time as we are hoping for. Our next speaker is Laston Chitembo. Laston is going to take us through some programmatic considerations on evidence-based interventions. And Laston Chitembo is country officer for HIV in the WHO Zambia office. Over to you, Laston.
Thank you. Next slide. Next slide. Thank you. So, with regards to programming considerations, I think we need to understand and respond to the local context. There's need to engage with communities and tailor our interventions in that regard, because it's important as well to understand that there are various needs in different settings, and those needs also tend to change with time. Another important issue is to ensure that we do interventions that are people and person-centered approaches, which is age and gender appropriate. We need to address both supply and demand simultaneously, not in isolation. Also, we need to understand that it's not about one intervention in isolation, but to think about multi-component, multi-faceted interventions on the pathway to effective service coverage. Next slide, please. So, with regards to program considerations for service delivery, consider approaches that are most suitable to the populations and their context, like mentioned in the previous slide as well. We need to improve access to service, reorient the models of service delivery, including to reach men in community setting. Quality is very cardinal. We need to enhance competence. This is a continuous process of our healthcare providers. Information is changing all the time. But also consider integration, because sustainability can be ensured through integration. And so expansion of VMMC into packaged services such as sexual and reproductive health, tuberculosis, and also engaging partners, and many other, basically. Next slide. With regards to economic compensation, first, address availability and quality of services. Compensation or other demand-side interventions will not overcome problems of supply and quality. And therefore, they need to look at both demand side and supply side. Identify what barriers compensation would address for specific populations and whether compensation will be the most effective and equitable way to facilitate men's access. Also, consider the potential expectations generated by compensation from your communities. Policies on financial compensation should be explicit and clear. Stakeholders and communities should be engaged, because this is very critical to decide on what sort of compensation, if introduced, its nature, then the amount to be dispersed or given. Ethical decisions making frameworks could support decision making. But most of all, human rights perspective is very cardinal. Use the framework for cash transfer programs. Next slide. My final slide looks at the research needs for enhancing uptake. So firstly, I think it's important to identify the barriers to VMMC uptake among men, and then two, assess the effect of interventions to increase uptake among men, including using program data. Then determine other men's service to add, including services for both younger and the older men. Assess preferences, assess feasibility and the cost and contribution to universal health coverage. Finally, whenever we do those studies, I think it's important and cardinal that we share the findings of service delivery research and lessons learned, because from that way, then we shall continue improving access of men and young men to VMMC. Thank you very much.
Thank you, Laston, and many thanks to our two last speakers of this session for keeping time as well. Very interrelated topics there, looking at the policy for men's health, but then looking at what exactly are the programmatic considerations for us to have evidence-based interventions for enhancing uptake among men. Thank you to our speakers for this session. I'll hand over to Katie for the question and answer session. Please feel free to type your questions in the chat box, and Katie will take us through the question and answer session. Thank you. Over to you, Katie.
Thank you so much, Lysias, and good afternoon and good morning, everyone. I'm Katie Lauby. I'm a Senior Technical Advisor for HIV Prevention at JPIGO. Before jumping into the Q&A, I just wanted to share one housekeeping recommendation. Several of you may notice that a number of the participants on this webinar are showing as usernames that are OCHLA3. We apologize for this. It appears that this is due to some system glitch. So if your username is currently appearing that way, we would ask that you attempt to rename yourself. Our IT colleagues will put a screenshot on the online so that you can see how to do it if you're uncertain, but you hover over your name and then click the button that says more, and then there's an option to, I think it's a right click to rename yourself with your name so that we know who's asking questions and speaking. If you're able to do that, that would help us. And again, we're sorry for that complication. So then into the questions. I think all of us, as we observe all of this helpful information being conveyed, are thinking about how we can actualize it in our own programs, but of course are still operating within the context of the global COVID-19 pandemic. And so we received a question from Eswatini, which is that in the era of COVID-19, are there examples of interventions that can increase service uptake without risking in-person contact? Or increasing the risk of exposure to COVID-19. I'll direct this question to Julie.
So that's an excellent question. And I think that basically the answer for the moment is we don't have those examples. So what we need to do is work together as a community, because we understand that many of you are facing serious service disruptions in this area. So this may be an area that as a community, we can continue to have these sessions going forward and have discussions and think through what could be opportunities, and also to think through and to hear any case examples that you may have as you're all trying to move forward on this area. So it's a perfect question and a perfect example of how we would like to take next steps after this this 3 series on the guidelines, which do not address the COVID issue, because it really wasn't there just when we were finishing up the guideline. So we do look forward, and please do indicate that you would like to have further sessions on this, and we can move forward with that. So thank you.
Thank you, Julie. And maybe just, oh, sorry, did someone speak? Okay. Maybe just for everyone's benefit, there was in the chat window a question about how to respond to WOLE's call for submission of case studies and best practices. And so thank you for your note in the chat window, WOLE, about the opportunity to submit to the malecircumcision.org clearinghouse. Perhaps we could type in the window just the email address that would be appropriate for the web manager there. And then there's also a question or a response from Bruce on the ECHO team, soliciting input from everyone on whether participants would appreciate an opportunity to share case studies and best practices live during future sessions of this sort. So please do feel free to write into the chat box about this. We are not currently receiving any other questions. So colleagues, if you do have more, please, please speak up. We can maybe wait a minute, or if Lysias, we are up against time, we can continue to collect questions and answer them at the end of the second half.
50, 60 questions.
Yeah.
So I can address one of the questions that came up yesterday, which was about the 50, 60%. The evidence that male circumcision reduces a man's risk of heterosexual acquisition of HIV by 59%, that's the point estimate, is from the 3 gold standard efficacy trials. And that figure remains the same. That's the best number that we can get. What these additional studies have done, these additional 17 observational studies that have been looked at, including studies where other prevention interventions are being scaled up, is showing that in that set of observational studies, there's a very consistent still reduction in risk. It's a bit different at a kind of an overall 50% reduction in risk, because these are observational studies, and these observational studies have different biases in them. One particular bias is that in I think it was four or five of the studies, there is a self-report of circumcision status. And now we know that there are some misreporting, so that people are then classified into a different group than what they're in. And this will have an effect then on the results. So that those 3 gold standard trials still remain as the estimate of an approximate 60% reduction in risk. And we are simply reinforced with what we're seeing with these additional observational studies. And again, we can have more discussion and more detail on this. This was a presentation yesterday by Tim. So if you would like that, we can do that also. I hope that that has helped to answer that question.
Thank you, Julie. And while you were speaking, we did receive a question, it appears from Namibia, though I think this would apply across the region, which is that one of the main challenges they are experiencing is the issue of seasonality, or the perception that when the weather is warm, it's inappropriate to be circumcised, and that there's a preference for cooler seasons. And so the question is just soliciting general feedback on whether there are any interventions specifically from the review that address seasonality. So I can direct this to Caitlin if you have any comment, and if not, we can ask our WHO colleagues to comment. And then I would also say, for all of our very experienced colleagues on the line, if you have any experiences that you would like to share in the chat window, please do feel free to type those in, as we are all learning from each other's expertise here. So Caitlin, if you have any comment from what came up in the review?
Thanks, it's a great question. I don't think it did come up in the review specifically, the issue of seasonality. Okay, thanks. Then Julie or others from the WHO team, would anybody like to comment?
I actually want to throw this out to the group. The group has done a lot of work in this area. It has come up over time, and the need to focus in on those time periods where it's more acceptable. But I think that there's probably more insights out there in the group than in the evidence per se that was that was reviewed. And so if anybody has anything they want to add, I'll just, our IT people, I think, our people will have to be unmuted by IT. So if you can put your, you can raise your hand, or if you're on video, which is great to see some faces, you can also wave madly your hands and let us know that you would like to be unmuted. So please do that if you have something you want to add on to the seasonality.
Great, thanks, Julie. And I do see a comment coming in from South Africa, from Sky. Thanks for sharing your experience on opportunities for demand creation without increasing risk of exposure to COVID. And so maybe I'll just relay this. And again, thanks for sharing so that others can benefit and also contribute to the discussion. But that, you know, when VMMC programs were either significantly slowed down or suspended during the pandemic, a number of staff were redirected to support care and treatment. And so, you know, they, by virtue of interacting in the community, were able to generate a number of leads and hold those names and contact details at peers for recruitment into VMMC as services became active, or if they were open to you know, allow those clients to appear as walk-ins. So I think the point here is that in the era of COVID-19, we have an opportunity to strengthen those linkages between technical areas and not rely solely on VMMC dedicated mobilization and demand creation to generate demand for the service. And this is, I think, and we welcome feedback from the group, but I think been historically challenging just with other technical areas and programs having their own mandates and being quite focused on them, that this might be a signal that we can, you know, we can better leverage those shared resources and people and time to raise awareness of VMMC when out in the communities for other services. And I think, and we're still seeing some more comments about just the shared burden of seasonality in other countries, including South Africa. And thank you. It appears that there's a link being shared for the contribute materials section on the clearinghouse. So you can see that in the chat window. And more information being shared. I see Caitlin sending links to the systematic reviews. No further questions at this time, though. All right, I think back to you, Geneva team. There's time. There has just been one question, I think, coming in from Tanzania, which is, which age groups do you consider when emphasizing enhancing uptake among adult men? The group that, do you emphasize the group that will have an immediate HIV incidence reduction? So it's just about age prioritization. If our colleagues in Geneva would like to respond to that one.
Sorry, can you show me the question? Is it there?
Depends what your gaps are. I think that's what you should answer. Yeah.
Yeah. Go ahead, Rachel.
I mean, I think you know best in your countries where your gaps are. I mean, if you've got very high uptake in one group and your priority group is another group, that's where you've got to use strategies to try and encourage that group to get circumcised. And I think that's going to be a challenge, you know, for countries that have really focused on the younger adolescents. If they're moving towards older adolescents and older and men at higher risk, probably some more creative demand creation strategies that link to those groups are going to be really important.
Thank you, Rachel.
That's okay.
Thank you, Katie, for the question and answer session, and thank you, colleagues, for sending through your questions and sharing your experiences in responding to the different questions. This is the end of part 1 of our session. We'll take a break and would like to be back at 3:30 to start part 2 of our session. Regarding the question on age prioritization, please feel free to reach out to data if you want to use maybe HIV infections or HIV incidence as a marker of risk. The data is there for men in 5-year age bands. Please feel free to reach out if you'd like that information by district. It's available by district for all of the ESA countries where VMMC programs are happening. That could be maybe one way to look at which age group is highest risk in what district, in what country. That data is available, more than happy to share. Let's take a break and be back at 3:30. Thank you so much for this session. Many thanks to our presenters in this part 1 of our session. Yeah, looking forward to part 2 of the session at 3:30. Thank you. Welcome, colleagues, to part 2 of our session today. Just a reminder, today we are looking at enhancing uptake among adult men and transitioning to adolescent-focused, sustainable voluntary medical male circumcision services. For those who joined us a bit late, just to highlight that there are 2 key objectives of this session today. The first is to share evidence-based interventions to enhance uptake of VMMC among men with a focus on service delivery interventions and economic compensation. And the second objective is to share the WHO framework on sustaining VMMC services and discuss country perspectives to transitioning towards sustainable VMMC services. The first part is already covered key topics, and we have heard from 4 of our presenters, Julia, Kathleen, Wale, and Laston. The second part of this session, we are going to hear 2 key parts. The first one, we are going to hear from Wale again on principles and framework for sustaining VMMC services with a focus on adolescent boys. And then we hear again a discussion which is going to be coordinated by Wale, where we'll hear some country perspectives on national programs. Over to you, Wale, on principles and framework for sustaining VMMC services with a focus on adolescent boys. Over to you.
All right, thank you so much, Alicius. And you know, there's been quite a lot of discussions as well in the chat, you know, on adolescent services, VMMC, which, you know, traditionally has been delivered in a vertical or somewhat vertical manner. The question has always been asked on how can such a service, a very effective service, be transitioned from that vertical or from that verticality into something that is more integrated, something more sustainable. And a chapter in the guidelines, chapter 6 specifically, deals with that. So what I will do with my presentation in the next 10 to 15 minutes is to give an overview. Just because of time, I won't be able to go into too many details, but I'll be sure to give an overview of the framework and the idea behind that chapter on transitioning to sustainable services for VMMC. So the overall objective of the chapter is to support countries, ministries of health, partners, as they transition from that, you know, what is currently a donor-driven, it's a predominantly vertical approach to one that is more country-owned, one that is more integrated and adolescent-focused. And of course, by doing that, there will need to be synergies. Again, there's been a lot of talk about this with other services and programs across the health system. So in developing the chapter, there were key principles that underlined what I will be presenting. The first is that transitioning would need to be adolescent focused. So we have that adolescent focused sort of feel to the chapter. And the reason, of course, is what we've said in terms of adolescents being at that stage where they're beginning to experiment with so many things, including, you know, sex. We can have that near impact on the HIV epidemic. The second is on embedding VMMC. So what has been delivered quite vertically, how do we integrate, how do we embed it into routine services? The third is on quality. So as we integrate and as we change the sort of way that we've been delivering the services before, we need to make sure that this does not tell on quality. So how can we ensure that we keep the quality and we keep people at the center of these services? The fourth is on accessibility in line with universal health coverage principles. And finally, on making sure that we have a co-produced approach that involves and meaningfully engages different stakeholders, communities at different levels. So we went through quite a few areas and methods in developing the chapter. Certainly we consulted so many stakeholders and experts across the building blocks that I'll be talking about. Many of them will be acknowledged in the chapter, and I want to say thank you so much to all of you. We had a period where we then had a selection of the framework. So what framework? How do we situate this, transition into sustainability? What are the components of that framework and the component considerations, all of which we came to with our experts and our stakeholders. In looking at what was selected, we had to, of course, also look into the literature on what has been done on sustainability in other areas and regions to sort of triangulate what we have. There were so many key informant interviews and that iterative feedback, including with the guideline and development group. A key starting point was on defining sustainability. And I have to say just upfront that we agreed not to go into any rigid definition of sustainability because there's no universality in that. What we did was to highlight key areas or key themes that came out from our consultations to define or to explain what we mean by sustainability. The first is on integrating and routinizing VMMC into established health systems. The second is on how VMMC services can be able to function effectively into the foreseeable future, of course, with the required quality, like I mentioned. Ownership, country ownership stood tall and very evident in all of the discussions. And then finally, on country-owned and country-directed domestic, but also external funding that can be coordinated through government. So the framework is a health systems approach. So we have used the health systems approach using already delivered building blocks of the health system. So WHO in 2003 came up with how to define the health system. So we sort of used that to decipher this framework. And in the framework for transition into sustainability, we have essentially 6 of them. The first is on finance, which is a key building block for sustaining services. The second is on health workforce. We have a building block on strategic information and data, one on supplies and equipment, leadership and governance, which is so key, and then finally, service delivery. Now, these building blocks stand on their own, but then we have the other question on what does this mean for transitioning to VMMC, to sustainable VMMC services? When we say finance, for instance, that's such a huge area. So what we have done for each of the building blocks is to go into the key components. So what are the key components for each of the building blocks that will be essential for countries to transition to sustainable VMMC services? Underneath, you'll see what we call critical enablers. And those are areas or elements that do not really fit into any of the 6 building blocks that I just mentioned. And I'll be just going into that as I go along with the presentation. So for each of the building blocks in the next slides, I will just highlight some of the key considerations and actions that you would find in the chapter. More details you would be able to find in the links which we have shared on the guidelines. So for finance, for instance, on ensuring that we have, that base of finance and budgeting that prevents, the sort of financial catastrophe that can happen in cases where you have to pay for services. There are 3 components. The first is on resource allocation and mobilization. For that, I'll just highlight the need for VMMC to be included as part of the National Essential Package of Services, as well as the move from, the external funding, well, not really a move, but the need to see how countries can also harness increased domestic funding while harmonizing the dichotomy between the donor financed elements and the national finance elements of the national budget. The second is on purchasing of services, and this sort of looks at how we can link, the resources and the funding that we have into performance. And in the chapter, which you can get more details on, we look at how we can move from what is currently a sort of passive purchasing of services into a more strategic and performance-based purchasing of services. Finally, on finance, we have, the almighty, really important as well, risk protection, financial risk protection through different means, waivers, especially for adolescents who do not have the means to pay for services, but also things that revolve around services as well. The second on health workforce, the three components on this to be able to have a health workforce that is responsive and productive to provide VMMC within routine health services. The first is on health workforce planning and to see how VMMC can be integrated into more broader national health workforce planning, and to see as well that in training our health workers, now we know that training happens in the different programs, but how can we make sure that VMMC is integrated into the trainings that happen for health workers? The second component is on pre-service and pre-service education and continuing education, and the need to ensure and to see how countries can advocate and move into including VMMC as part of national pre-service training and continuing education. And then finally, on management, support, and supervision. So these are the three components of the health workforce, and the need to see as well how, adolescent-friendly and responsive services, how when countries and programs are going on supportive supervision visits, for instance, how can we ensure that VMMC is part of the package that is done? The third, or probably the next, I'm losing a bit of the count now, is on strategic information. Now this got quite a bit of nuanced information as well in the guidelines. I invite you to look at it, but it is to see how countries can move and transition from what is currently parallel systems in many cases of strategic information structures, data structures, into a more country-owned, integrated, and less donor-dependent structures for data use and analysis. There are three components here. Again, I'll touch on just the key ones. So on data collection and management, one of the elements that is provided here in the chapter and in the guidance is on moving from the paper-based data collection systems into electronic information systems, so transitioning towards more electronic systems, but also, like I said, reducing those parallel systems or perhaps harmonizing them for better country effect. These other components here are on data quality, but also on safety monitoring. There's a lot as well on safety monitoring, and to see how the current VMMC safety monitoring systems can be routinized within national systems. The next building block on supplies and equipment. This had we had some experts as well here who gave us as well, three components. So here we have norms and standards, and seeing how our strategic guidance on the rational use of VMMC supplies can be part of what is part of the national package or on supplies and equipment. Procurement and distribution, the whole supply chain, to see how logistics systems and the supply chain management systems for VMMC is routinized and part of national services. Also to mention here, just before I go to the next slide, on waste management, something you will find in the guidance as well on supplies and equipment is on how waste management systems can be well enhanced to address segregation, storage, transport of waste. The next is on leadership and governance, and I'm very happy that we have, a lot of program managers here on the line. But here we have four components actually on leadership and governance, leadership and coordination, having the ministries of health, really at the forefront, having VMMC focal points as well, harmonizing the roles and responsibilities of VMMC focal points with broader health focal points. An example is countries have adolescent health focal points, for instance. We need to see how they're part of their work and part of their scope is is VMMC elements as well. And then finally, like I mentioned, on integration of VMMC into the essential package of health services. So finally, on service delivery, we have, and this is quite key, and I'll just touch on reorienting service delivery models. Now, a key to changing what we want to do is how we can reorient what we have currently into services that are more integrated, but also adolescent friendly as well, as this has quite a bit of an adolescent focus, and also on empowering and engaging people, reaching the underserved and marginalized with VMMC services. I mentioned the critical enablers, which couldn't be put into set building blocks, but here we have the need to continue with meaningful engagement and participation of adolescents, community engagement, including with parents and traditional circumcises, multi-sectoral partnerships from surgery to sexual reproductive health, mental health. I think it's important how we can have those partnerships and of course having our laws that enable quick, able, quality access to VMMC services. So this is an overview of the chapter, which has, like I said, the building blocks, the key components, considerations and actions that you would find in the chapter. You can find more details in the chapter when you get them, but also we know that we need to move, from what is currently a policy into practice, into activities, and we'll be very delighted to continue to work with you as we've done into moving into this. So finally, just key messages. The key message is that as we move, from what is currently a vertical system, we need to ensure that we have services for adolescents. Services for adolescents are that critical next step into providing services with sustained coverage for VMMC. We need to see how countries can take that prominent role in mobilizing, in allocating resources, but also in the service delivery. Support and supervision, we need that people and person-centered care for delivering adolescent-friendly and integrated services. I've talked about country leadership, but then finally on partnering. Many of the questions that I've seen in the chat has to do with how we can engage and partner with our communities of practice, with organizations, with networks. I think this will be very key as we move forward. Thank you, moderator.
Thank you, Wale. This is a very great summary, and I should say now it makes it easy to go through this framework document after this overview from Wale. This document, it's a very concise, well-organized ideas and very easy to go through, especially after this presentation from Wale. When you go to the document, you can relate with how it is structured and the key messages in the document. Again, the next part, which is the last part of this part 2 of the session, is going to be Wale moderating a discussion with a few countries. We have heard now the principles underlying a framework for sustaining VMMC services with a special focus or particular focus on adolescent boys. Now we want to hear some experiences from countries. Over to you all again to moderate a discussion with a few countries implementing VMMC services.
Right. Thank you very much, Lysias. And I have to say, this is one of the most exciting parts for us as well, because, having looked at the guidelines, it's important to see how they can be put to practice. It's not just about the policy. It's really about implementing them and practicalizing them, if I can use that term. So in doing that, following my presentation, we have, the real people is what I would say. The real people who are doing the hard work of implementing these services, of leading countries towards sustainable services. And on the line today, we have Sino Kaba, I hope I'm pronouncing that right. I've tried. But Sino is the VMMC lead with the Ministry of Health in Zimbabwe. On the line as well is Albert Koanga, who is with the Zambia Ministry of Health. He's also the VMMC lead. So I'm just so delighted that we can have both of you. If you're unmuted, you can just say a quick hello just before we go into the questions and the chat. Can you hear me, Sino and Albert?
Yes, thank you. Good morning and good afternoon, colleagues. Sino Kutemba Klava. Thank you.
Fantastic. And Albert?
We need him to get.
Could you unmute yourself? Are you able to do that? Okay, so we have no audio for Albert. So if the IT can help us to sort that out. Can I confirm if is Ambrose on the line? Ambrose Juma is from the Kenya Ministry of Health, and he had a few problems connecting. So I just want to see if that has been resolved and if he has joined. Ambrose, can you hear me? Right.
He may be muted also.
Okay, so while we solve, or while we try to resolve the technical problems, we can hear Sino. So I'll start with Sino, and there's been quite a lot of work. I'm aware of what you have done in Zimbabwe, and it's a huge pleasure to be able to hear some of those some of your experiences as well on transitioning towards sustainable services for VMMC. And if you could just briefly talk about, just an overview, just very briefly, how can you describe the work that has been done in Zimbabwe on sustaining VMMC services, Sino?
Thank you very much, Wole, for inviting me and also for inviting Zimbabwe as a country in this discussion. As you are all aware, mainly after WHO set out some recommendations. We then entered later on in 2014 into a massive scale-up phase, and this scale-up phase was really focused at us getting to 80% of our target population. And we did manage to achieve that in 2018, where we got to 1.3 million circumcisions. However, this was at national level. When we looked at our data at district level, there was lots of variability at that level. Now, we did that through a strategy we called the Accelerated and Costed Operational Plan, where the focus was a business unusual approach. Now, at the close of that strategy, we then put up a follow-on strategy, which we have called the Sustainability Transition Implementation Plan. This Sustainability Transition Implementation Plan is looking at how do we move from the current high-paced, high-volume service delivery approaches to a more sustainable way of doing business, where in the long term, we're able to sustain the gains that we already have achieved. And so there are quite a number of things that we did, and some of them are actually quite similar to the building blocks that Wole just highlighted. So we engaged in a nationwide consultative process with different stakeholders. And our starting point was defining what sustainability within the context of Zimbabwe meant. And I'm happy you already mentioned the major differences that are in sustainability. So we looked at sustainability, we came up with a definition where we're looking at maintaining services at 80% and above in a routinized manner, and also through conformity to social norms and local ownership, and also in an affordable and acceptable as well as accessible manner. And the characteristics of that phase, our desire was that there is extended reach of services, The services are also affordable and are cost-effective, and the programs are rooted in community, and the services were tailored towards specific target cohorts, being guided by our evidence. And the two major points that also we discussed about is how do these services get integrated into non-HIV services and HIV services as well. And then the program is also sustainable. So we came up with 8 points that I'll just touch in brief. So the first one was in leadership and governance. So in this, we're looking at how do we reorient our services so that from the current semi-vertical, the program is actually run within fully within ministry settings. And we have developed a tool which we have called the VMMC Transition Assessment Dashboard. And this tool now we use it to measure how the different pillars are moving. For instance, if we're looking at leadership and governance, we are then saying, how is this program being, how can we measure that the ministry is owning this now, or at least is moving towards? And we look at service delivery, we look at financing and across the board. So the second pillar is the health information system tool. We actually also measure that at the beginning of our sometime last year and into early this year. And then also in health information, what we are looking at is how is the VMMC data managed, and already within our country, the data is already within the national system. Partners request for that data and then feed into their own system, particularly for donor reporting, but otherwise there is one system that is in place. We have one system also of commodities where all our commodities, the quantification is done from a central point. We provide the assumptions and we participate in the quantification, and it's done together with all the other commodities for HIV and non-HIV services. And we also have started the transition from using disposable commodities to non-reusable, to reusable commodities. So what we have observed is that from our assessment, this would result in about a $10 reduction in the price of VMMC. In service delivery, the integration process has actually started. And most of the providers, over 90% of our providers are actually Ministry of Health providers, with partners also providing some support in other areas in terms of the workforce. And the last bit I'm just going to touch on is on financing. Our program is largely partner funded. Of course, we do have some resources coming from government through the AIDS levy, and also the personnel that are employed by government, and also the infrastructure. But in terms of commodities for use, these are largely financed through partners. So this is where we are at the moment in terms of moving the program towards sustainability. There's still lots of work that we are doing. So in terms of moving this program forward, in summary, is that we're still looking at how best we can consolidate what we have done in terms of trying to move from the current initiatives on sustainability to long term. One of the things, of course, that we have observed in the process is that VMMC sustainability should actually have started when we started the program in 2007 to 2009. So that it doesn't come at the end when we have reached 80%, then that's when we start trying to put up, it becomes difficult. And also some things may be lost in transition. And we currently are putting up mechanisms of lobbying with our government to see how best we can actually have more resources towards HIV, but also towards VMMC in particular. And our major thrust really would be how can our partners support in this process where we are transitioning services from the current way that we're doing to a more long-term sustainable way. And one of those things is that the government already has a results-based framework that it is using. And for VMMC, we're using a slightly separate system, and there are discussions that are currently underway to say how do we bring this together so that the VMMC also falls under the results-based financing that government is already using for all the other programs. Thank you.
Okay, thank you so much, Sino. That was comprehensive and I mean, a lot of great experience as well. Just before I go to Albert, I'll just ask just one follow-up question, and I'll just keep you to 1 minute on this. So you mentioned the sustainability assessment dashboard, and I wanted to just get a quick feel of your experience on this. In using the dashboard and in assessing and for assessment, are you having to bring different stakeholders from different areas that are outside of VMMC? And how difficult has that been, or how easy has that been?
Thank you. So the assessment dashboard that we have it's a multi-layered. So from a national level, we assess the province, and then so we bring together the stakeholders at the provincial level, and we administer this dashboard. From there on, the provincial level then moves further down to district level. So you can actually assess this dashboard by a province. You can also assess it by a particular pillar within the program. And so the province then also further assesses the districts and the facilities. What we have noted is that it's not been easy initially to get started, because we had some questions that we have to refine and revise. But also, sometimes we observe that the provinces and facilities, they felt sometimes that this appears as it's assessment of performance. Yet in actual fact, it isn't the assessment of performance, but it is assessment of movement towards sustainability from the current implementation. So we are going to be having our second round of assessments next year, but we already are in the revising some of the questions as per recommendations from the districts and also from the provinces.
All right, thank you, Sino, and looking forward to following up on those assessments. So I'll just move on to Albert. Albert Kwanga, who is from the Zambia Ministry of Health. And I would just like you, Albert, to share your experience as well on transitioning towards sustainable VMMC services in Zambia. If you could just take us through the key points and as well, maybe the key challenges as well that you've had across the building blocks that I mentioned, that I'm sure you're working on as well in the country. Albert, over to you. Thank you.
Thank you very much, and good afternoon, everyone. Can you hear me?
Yes, we can.
Thank you very much. So we've been providing VMMC in Zambia since the year 2007. And to cut that long story short, I think the program has found acceptability in all parts of the country. We have circumcised not less than probably 2,200,000 males in the country. Now, the program thought of now moving forward, how do we sustain VMMC? So the ministry has been having held a few meetings with partners, and this was like a preliminary meeting. So we defined sustainability. I don't want to go into that definition. We looked at what is it that we need to have, where do we need to be for us to say we have a program that is sustainable. So we came up with a sustainability plan. This was signed off. It is complete. And then we looked at the various pillars of the program, which often correspond to the building blocks of the health system. So we decided to go ahead and strengthen coordination at all levels so that people can own the program a little bit more. And then we decided to widen engagement by going outside the traditional borders of the health system through the engagement of other government ministries such as this youth and sport, as well as education and others. And then within the Ministry of Health, we decided to engage also wider. We brought in the unit that looks at adolescent health, reproductive health. I'm glad Mabel has been quite instrumental in that. And then we brought health promotion and others. In terms of service delivery, we decided to continue decentralizing the service to all levels of the health system. We continued also to engage, both at be it at provincial, district, as well as facility level, engaging the community as well. So then in terms of human resource, the role of the central level now is to train trainers of trainers. Then providers are now being trained at the lower levels. So we want to do more of coordination as well as governance. And then we introduced e-learning. This is on HR. And then we continue to do task shifting as well as ensuring that VMMC is included in all aspects of HIV programming as an additional strategy for HIV prevention. Then there was a question that was asked, which building block has been the most challenging? In Zambia, I'll say it's the supply chain building block. That's where we have been having problems or challenges. The way supply chain is managed, we have a number of partners who support the program, but each partner plan, quantify, they do their own costing, and they buy VMMC consumables or commodities. And oftentimes you have these being delivered direct to the facilities. Now, while this ensures that we do have these commodities at service delivery point, there are a number of challenges that actually are there. One, when these commodities are delivered direct to the facility, often they are not visible to the program managers at district level as well as at facility level. So sometimes it becomes difficult to set targets. And then you find that there are some facilities, health facilities, that will have more than what they need. Others will have a shortage. So we've been having challenges where we feel that if we could harmonize this system, it would be better. Then you find that also procurement decision or quantification decisions are often made based on maybe just program data without looking at other parameters in quantifying the supplies. So the challenges that we've been facing have resulted sometimes in certain parts of the country having challenges meeting their targets. And then also there's been a risk of expiry of some of these commodities in places that have been undersupplied. So what I've described is what we have been seeing in country as a challenge in terms of supply chain management. So the ministry and partners began engaging one another not long ago. Meetings were held. The aim now is to ensure that we have a single and harmonized logistic management system for VMMC commodities. And we don't need to look far. The country can learn from other programs that have been around for a longer time, such as the ART program, the TB program, malaria program, and as well as other programs who, despite having a number of partners working together, supporting the country, they've had at least a supply chain system that is harmonized. So as I speak, engagement has occurred, and we intend to move forward by having a single and harmonized quantification meeting so that we come up with a one procurement plan for the country, so that whatever is procured in the country will first of all have to pass through the central medical stores so that it is entered in the system. It is visible to all program managers and players at all levels of the health system so that we can be accountable to one another as partners, and so that there is visibility as well as ownership. So that is what we intend to fix going forward so that we can make the program even much more sustainable. We've had a few other challenges before. We had the information system that was fragmented, but we worked on that. We want to use the same approach so that we can have a single harmonized logistic system for the VMMC program. Over, I submit, Chair.
Fantastic. Thank you so much, Albert. That was clear. That was practical as well, which is exactly what we want. So I'll come back to you and Sino for closing comments. But I just wanted to check again, is Ambrose on the line? Ambrose?
Yes, I'm on the line. Good morning and good evening for the rest of the members.
Okay, thank you so much, Ambrose. We sort of missed you at the beginning, but I would just like you to come in, just building on from what Sino and Albert had mentioned. Both their sustainability plans were worked on across building blocks. I mean, certainly I know you're familiar with that. We were in Kenya, we worked as well together on some of this. And I just wanted to take you on across the building blocks. Could you just say to us what has been your experience in terms of which is, or which of the building blocks has been the most challenging for you in the great work that you're doing in Kenya, Ambrose?
Okay, thank you very much. So you just want me to respond to that right away, or start from up about what we are doing about sustainability?
You can respond to that right away, please. Okay.
Yeah, in terms of the most challenging building block for the country, what we appreciate and acknowledge is that all the 6 building blocks are intertwined. So in one way or another, they affect the program. But what we find as the most challenging in Kenya is the service delivery building block. And the reason why we think this is one of the most challenging one is, one, the mode of service implementation. The way VMMC was started, it was a very good thing as a vertical approach from the beginning. But over time, it is posing now some challenge, because when we look at the circumcisions,
right,
if somebody is just employed to do circumcision alone, there are times when the clients are not there. So that follows that person is idling. And that is not cost effective enough. So for us to have synergy, it will be wise that we have an integrated approach so that the mode of implementation now will be more, will give more fruits other than only VMMC, because the standalone sites cannot be sustained as a country. Yeah, the second thing is that when you look at the vertical implementation, there is increased VMMC operation costs. Because when you look at the people employed, the kind of outreaches they are doing, the vehicles they are using, overall, you realize it becomes very expensive to implement. And more so when we are thinking of transitioning to sustainability, it will be difficult for the counties or districts in some other places to implement such a mode of implementation if we are to sustain it. So there's a question of cost. And the other one is, and this one I also had one of the first presenters was talking about economic compensation. Economic compensation or incentivizing VMMC is a good thing. But if it's not well thought of, then is something which is subject to abuse. If I just quote, for instance, what we had here in Kenya, is that for us to encourage people to come, the providers were getting incentives that if you circumcise such a number or exceed such a number, then you get an incentive as a way of making them to perform more or better. But the inherent challenge in that is that the one circumcising is not in charge of mobilization. So he may be willing to do more, but those who have come are fewer. At the end of the day, this one who was willing to circumcise more, but they were not there, is taken as one who has not achieved the target and therefore not eligible for the benefit of an incentive. And this in itself brought a challenge because those who didn't now attain the number required to get an incentive posed the risk of being discouraged or delusionist because they were not also benefiting from the incentive. So economic compensation or incentivizing VMMC is a good, but it should have a specific time frame. Otherwise, in terms of sustainability, that will be not easy. The other challenge that about this service delivery we are faced as a country is the approach. Is the approach that we have now witnessed with COVID-19. You realize the PEFA year starts October and ends September. So October 2019 to September 2020, as a country, we had anticipated to circumcise 200,000 males. But when COVID came, and then—
Right, Ambrose.
Yes.
Thank you. Yeah, thank you. You know, really great insights, and you've actually gone into a lot of the areas that you know, given more time, we would love to touch. Just so that we can round up, and because of time, I'll just give you know, everyone just 30 seconds. So all of the presenters, the speakers who have done really great, I'll give you 30 seconds to just say, you know, very specifically, what is the key ask? So in terms of transitioning to sustainability, what will be that one key ask that you would like to put forward to listeners, to partners on the call today? So I'll start with Albert, please.
Hello, good afternoon, everyone again. Thank you. I think for us, what we need to do is to make the VMMC part and parcel of service delivery so that it's a routine service. And then we need harmonization, yes, across a number of these building blocks so that it does not stand alone. I think ownership at all levels is also key. There is a lot that we can learn from the programs that VMMC found on the scene. Sustainability is achievable. Let us integrate it with other services. Then it will go on and on and on. Thank you very much.
Really like that. So thank you, Albert, for that concise points. I'll now go to Ambrose. If you can give in 30 seconds, what would be that one key ask, Ambrose?
Yeah, the one critical ask I'll say is we phase out the standalone VMMC sites in the country, and the VMMC sites be located in mainstream health facilities. The other one, for counties that have sustained VMMC saturation of 90 and above, we start piloting on the integration so that counties are prepared well enough to take up the service. And the third one is that, as we know, Kenya is a circumcising country, and therefore we are looking for alternative ways so that we continue with the circumcision of the 10 to 14 years, because for us, this is the age group that accounts for up to 70% of our total numbers.
Okay.
And the last one is that as a way of human resource development, we had started a pre-service VMMC training module in colleges, and they have started training the clinical officers and nurses at pre-service level. But the challenge we face is that their labs are not equipped to carry out the surgeries. So we asked for support so that we equip the skills lab in the colleges for them to continue doing the learning and the practicum in terms of VMMC kits and pharmaceuticals.
Thank you very much. Great, thanks, Ambrose. I would now, really great points, I have to say, fantastic. I'll go to Sino to finally just close us off here with his final summation. Sino, please.
Thank you so much, Ole. So for Zimbabwe, like I mentioned earlier on, one of the major challenges is that our funding is mainly partner funded. And so moving forward is to actually continue lobbying internally so that at least VMMC is also part and parcel of the programs that are directly funded. But looking forward to international and multilateral institutions, for instance, like the Global Fund, the PEPFAR, and also the UN agencies, is to actually support this transition in an integrated manner. And also with specific mentions. For instance, when we're doing the recent Global Fund application, one of the things that came as a condition is that this grant should be focusing on HIV prevention. And on HIV prevention, there are these 5 or 6 programs, which included VMMC. And that makes it very critical to help countries actually start moving and prioritizing certain HIV prevention interventions. And I also did mention that sustainability is a process, and we should have started earlier, but I think it's not too late to start even now. And also for other countries, it will be important to, wherever you are, at what stage, no matter what stage you are, it is good to get started with introducing sustainability work. It will actually sustain what we have done in the so many years that have gone by. Thank you very much.
Great, thank you so much. And that's a great way to just end and hand over now to Lysias. I'd like to thank all of you, of course. Thanks a lot.
Thank you, Wale. I can see a lot of interest, I think, in this discussion on these 2 key aspects. We've gone through the principles of the and the framework for sustaining VMMC services and these country examples from Zimbabwe, Zambia, and Kenya. I'd like to hand over to Julie for the next steps. Over to you, Julie. Thanks.
Thanks, Lysias. So as far as the next steps, one of them is the attendance certificate and evaluation form, which the link is indicated in the chat. It is also included on the invitation form that you received. And so you can use either of those links to get in and to complete that evaluation, which is greatly appreciated so that we can all continue to improve this new world we're working in of a lot of virtual sharing and learning. And once you've done that, you should receive, you have 48 hours to complete the evaluation certificate, and then you will receive that electronically nearly immediately. So please do that, both for your own benefit and for ours as well. And regarding the next steps more broadly, we have certainly learned from our experience over the last 3 days, and we see the interest for further discussions. We would like to make those, or further sessions, we would like to make those sessions much more interactive. And we have heard now that there are several areas where you certainly would like to have further sessions, including on the issues around adolescents and VMMC, particularly younger adolescents, and also this issue of VMMC now in the context of COVID. We see several examples have been mentioned, and I think what we will do is approach you, those of you who have those examples, and see if you're willing to share those so that we can get some more case-based learning and discussions going on. We also have worked with some of the other partners to develop an assessment tool to look at services before initiating them again, since there has been a break in many services, and it's important to ensure quality and safety and that everybody's up to speed as they restart the services. So that is our plan, and we hope to get something moving within the next couple of weeks. The first one may be the more simple discussion session to answer and have more discussion around the adolescent and MC issue. But please do take this opportunity to add into the chat window any other areas or your top priority areas that you really would like to have more of these sessions on. And so I just want to give my thanks to all of you for really being engaged throughout these 3-day, 2-hour sessions. And with that, I've finished on my next steps, and I pass back to our moderator.
Thank you, Julie. It has been a great session today. Thanks to you all for your engagement, for the questions, and for staying awake for this past 3 series of these sessions on VMMC guidelines. It has been stimulating discussions today. Great to hear from countries as well. I would like to give to our WHO Afro Medical Officer and HIV Treatment and Care, Dr. Frank Lule, for our closing remarks.
He's diverted to another meeting, so Rachel will.
I'll hand over to Rachel in his place. Thank you.
Yeah, thanks.
Yes, thank you very much, Lysis, for being a fantastic moderator. Thank you for sticking with us, you huge audience. We really are very, very appreciative that you've stayed the course, and we've learned a lot, as we will take all your suggestions on board. I think another thing that we would like to think about is a way that we can keep this community of VMMC experts engaged and as a group. And I think we're going to discuss as a small team a way of doing that, maybe through a VMMC WhatsApp group or something, so that we can continue the discussion, because there is so much to learn from you. I think in the chat, in the country discussions, we know huge amounts of experiences out there, huge amount of ways of getting over problems, but we're not really capturing that and learning sufficiently. So we would really like to facilitate that sharing of knowledge. So thank you very, very much, and watch this space. We'll be in touch with you, and we will be offering further sessions, further engagement, and we want to continue this momentum and not stop. And as I say, please do look at our guidelines. It's thanks to you that we have them. Many of you have reviewed them and inputted into them, and we hope they'll be useful for you. Thanks so much, and thanks, of course, to Julie, who has led this process with Wale. They've been the instigators and have worked tirelessly over the months and months to produce the guidelines and plan these sessions.
Thank you, everyone. Goodbye.